I'd like to welcome everybody to our program, Optimizing Patient Outcomes in Bipolar Disorder, Long-Term Management of Major Depressive Episodes. So we're going to focus on actually the most common aspect of bipolar disorder, and that is major depressive episodes, which brings our patients in to see us and desire treatment. I'm Dr. Leslie Citrome. I'm a clinical professor of psychiatry and behavioral sciences at New York Medical College in Valhalla, New York, and I'm joined by my good friend and colleague, Dr. Joe Goldberg, who's clinical professor of psychiatry at the Icahn School of Medicine at Mount Sinai in New York, where I'm also, by the way, adjunct. And that's a long story, Joe, and we'll talk about that some other time. My disclosures are as on this slide. I receive a small amount of royalties, and I make a living as a consultant and educator. I also see patients. That's not disclosed on this slide. I think that's rather obvious. And I have a lot of interest in the development of new products to treat psychiatric disorders. I work in their development in terms of the design and interpretation of the clinical trials, for example, and really keen on that. And I know Dr. Goldberg is equally interested and has also similar disclosures and as well as royalties. And he gets a bit more royalties than I do because he's actually more active in writing books. And he wrote one recently that I'm sure he'll mention during the course of our conversation this evening. So we're going to have the opportunity to talk about formulation of a differential diagnosis of major depressive episodes, MDEs, associated with bipolar disorder. We'll call that bipolar depression. We're going to spend a great deal of time talking about that. We're going to spend time and effort to differentiate it from unipolar depression, plain old major depressive disorder, because that will dictate treatment and prognosis. We're going to propose appropriate and effective treatments for bipolar depression specifically, and integrate strategies for the treatment of patients with bipolar depression and physical and psychiatric comorbidities as well. We're going to apply management and patient education recommendations and current clinical practice guidelines to our routine care of patients with bipolar disorder. And we hope to do that. Have plenty of time for questions at the end. So let's move on to the didactic presentation, and we'll see you soon. We're going to start off by talking about how we can improve the diagnosis of bipolar depression. How can we make it more accurate? Dr. Goldberg?
Let's just start by asking, what is bipolar depression? By definition, bipolar disorder involves high periods, either manias or hypomanias, as well as major depressive episodes. So people with bipolar depression have at least one lifetime major depressive episode in addition to manias or hypomanias. It's often been noted that people with bipolar disorder may not necessarily be as aware of their high symptoms as they are of their low symptoms. And in fact, the concept of anosognosia, or loss of insight, is sometimes thought to be one of the neuropsychological phenomena that comes with this disorder. And patients may even identify their depressions as if they are highs, or identify their highs as if they are lows. So it really takes some level of critical evaluation of patients' presentation, signs and symptoms to really kind of get clarity about this. Patients with bipolar disorder often do have more insight in the depressed phase of the illness, although I'll add one exception to that, which is that psychosis is somewhat more commonly seen in the depressed phase of bipolar disorder than unipolar disorder. So the clinician really wants to be quite attuned, not just to ticking off symptoms of a major depressive episode, as well as capturing a historical background of a mania or a hypomania, but some of the nuanced features around psychosis, as well as the qualitative aspects of a major depression. But if we talk about depression per se in bipolar disorder, it's been noted that depression in some form or other is the predominant symptom that we see over the course of time. It's the most often presenting polarity in people with bipolar disorder. They are more likely to have a depressed phase of illness before eventually going on to have a mania or a hypomania. We'll talk in just a bit about how that can sometimes contribute to underdiagnosis or misdiagnosis. Manias or hypomanias, or mixed features in the older DSM-4 sense, tended to be less commonly seen in first presentations. And then over the course of time, we know from long-term follow-up studies going out as much as 15 to 20 years, the time spent with mood symptoms is much, much more comprised with the depressed phase or depressive symptoms as compared to prominent signs of mania, hypomania, or mixed features. And then we can talk about some of the impact of depression. The highs can cause you trouble. They're often evident to other people, but even with the depressed phase, patients themselves will self-report, compared to the general population, lower levels of satisfaction with their overall health, with their own mental health, quality of life in terms of work and social functioning and family life, are self-identified among people with bipolar depression as being lower than is the case in the general population. So they know something is off. They may or may not be able to put their finger on it. And part of our challenge as the interviewers or the assessors is to not just say, are you depressed, but what kind of depression this may be. And seeing this marked impairment is one of the tip-offs as well. Unipolar depression certainly can be impairing. But when you meet someone who's had many hospitalizations or grave impairment, real trouble functioning, and you start to scratch your head and think, is there more than, quote, just depression going on? You start to think about these things. Another piece to this is it's not just the immediate severity of a depressive syndrome itself that sort of puts the kibosh on functioning. You have a graph on this slide from the Stanley Foundation study looking at the detriment seen in overall psychosocial functioning, not just in syndromal depression, but even in subsyndromal depression. To me, this is always one of the biggest challenges because we think about sort of making inroads in someone's most fulminant presentations of illness, but the job's certainly not done just because someone's depressive symptom severity has diminished. And even if we can say to the patient, well, look, you're better. If I'm using a rating scale, I could even say, you're 52% less depressed than when you began, but that may still leave an awful lot left over. And that correlates with trouble with work, trouble with social functioning. And our patients don't really care what their rating score is. They want to know if they can go back to work and what's going to be an obstacle to dealing with their lives. So even though depression may not be fully syndromal, it can still be markedly more impactful on their functioning as compared to no depression. And then if we think about the burden of bipolar disorder, the most catastrophic outcome of all certainly is suicide, a leading cause of death in people with bipolar disorder. Population studies tell us that people with bipolar illness have a lot of reasons for shortened lifespans. There's about a twofold increased standardized mortality ratio compared to the general population. And it's certainly in large part contributed to by suicide, a 15 to 20-fold higher chance of dying by suicide if you have bipolar disorder than if you're in the general population, correlates with a younger age and earlier age at onset. This is an illness that tends to strike often when you're trying to establish your developmental milestones and move forward in life, complete your education. That becomes psychosocially very difficult. But when you think about it as well, it's not just suicide. We'll see in just a moment. There's an increased risk for all-cause mortality. If you have bipolar illness, the chance of premature mortality from all causes, even accidents, is much higher. Suicide can't really be predicted, but we can certainly look at risk factors. Having a psychiatric diagnosis is itself a risk factor. As we mentioned here, having bipolar disorder is especially high. And the depressed phase, either by itself as a pure depression or as a mixed presentation, becomes of concern. So we see 15% of patients with mixed features have an increased risk for suicide. Now, if we turn to the next slide, as I mentioned just a moment ago, an increased risk of mortality, double the cause of mortality compared to the general population. Cardiovascular disease, about a 10-year shortened lifespan. Accidents, homicide, violent deaths, increased risk of diabetes, pulmonary disease, on the whole, a 10 to 20 year shorter lifespan. Reminds me that much of what we're trying to do is not just to improve symptoms or quality of life, but quantity of life as well. If you think about many of our patients having medical comorbidities, they may not necessarily get the best care or be so proactive in procuring their own care. And part of what we want to do as healthcare providers is get some sense of someone's risks for cardiovascular disease, for obesity, smoking. 80% of people with bipolar disorder smoke cigarettes. Metabolic dysregulation, a much higher risk compared to the general population. And as we're choosing our treatments, trying to minimize adverse effects that could compound some of that medical morbidity that comes with the diagnosis itself. So I said a few moments ago that misrecognition or misdiagnosis sometimes might be the result of, well, if I come along with an episode of depression, I've never had a mania before, until I go on to have a mania or a hypomania, my diagnosis at that time, at least, is unipolar or major depressive disorder. So the challenge for the clinician and the patient alike is to sort of get a sense of what is the likelihood that this individual before me who now has a major depression may go on to have a conversion of polarity from unipolar to bipolar disorder. This gets very tricky. The things that I often think about are, we mentioned a bit earlier, early age at onset, especially pre-pubescent, adolescent, or pre-adolescent depressions, anywhere from a 20 to 40% risk for eventual polarity conversion. A family history doesn't have to be there. This is not a Mendelian trait, so it's not like cystic fibrosis or muscular dystrophy. And even if you have an identical twin, the concordance is not 100%. It's somewhere between 65 and 80%, but it's another piece in the puzzle. If you have a first degree relative, anywhere from a 10 to 25% increased risk. Recurrent brief depressions make us think about bipolar disorder, psychosis during depression, atypical features, reverse vegetative signs, overeating and oversleeping. I like to think of this sort of like building a story or putting together jigsaw pieces so that you can not just ask someone or their family member if they've ever had an episode of mania or hypomania, but just, again, trying to put all these corroborative pieces together, since many patients may never have been asked about a manic episode or may have had some sketchy details about it when they're even self-reporting. On this graphic to the right, we see common misdiagnoses in patients with bipolar disorder. This is from some Manic Depressive Association data. I always like to think about the ways in which patients may present with something other than a manic episode and be identified with whatever they're presenting with as the predominant problem. It could be just depression, it could be anxiety, it could be psychosis, it could be personality problems or substance use. And I often wonder when I see these data, how much of this is misdiagnosis or incomplete comorbid diagnoses, because we know that most people with bipolar disorder have more than just bipolar disorder. Anxiety disorders of one form or another occur in more than half of people with bipolar disorder. Substance use disorders, anywhere from 40 to 70%. Psychosis can be a problem. You're allowed to have a personality disorder and a mood disorder. And so depending on, I guess, as they say, which part of the elephant one is touching, one may make some formulation as to what's going on. But high comorbidity makes us want to think about a bipolar diagnosis as well and step back and make sure we haven't missed a previous mania or hypomania. Because if you do, consequences, inadequate or inappropriate treatment, worse outcomes, further functional impairment, and a really hard time giving the patient and the family an accurate sense of what's to come ahead in terms of prognosis. Russ, I'm going to turn things back to you at this point.
Well, I have to say that's a lot of things to consider when evaluating someone who presents with a major depressive episode who may have bipolar disorder. A lot of things to think about, not only in terms of bipolar disorder, but comorbidities. It's certainly a challenge when someone isn't telling you everything you need to know, and they may not even know what you want to know. So let's go over the fundamentals now, differentiating between MDD, bipolar type 1, and bipolar type 2 in a person with a major depressive episode. What does the DSM-5 tell us? Well, first off, major depressive episodes can occur in all three disorders, MDD, bipolar type 1, bipolar type 2. The criteria for a major depressive episode is identical, and on cross-sectional examination, they look the same. The only way to tell them apart is longitudinal history. With MDD, there's no history of mania, no history of hypomania, and it's like a plain vanilla story. Onset maybe in the 20s, 30s, or 40s, and it seems to come on gradually. There's no complicated life history of multiple jobs, multiple marriages, chaos. It seems kind of steady under many situations. Bipolar type 1, in order to make that diagnosis in someone who has a major depressive episode, you have to have a history of at least one manic episode. That's not always easy to get if that person is trying to not tell you about it. You need collateral information from a loved one or friend, and they'll tell you. So one thing I do, though, is I ask about things that a manic person would experience and not necessarily see as a big problem. Like, have you ever gone through a period of time where you didn't need to sleep very much? Like you had a lot of energy. So that's not considered like a negative. And people will own up to it much more readily than asking them if they've had promiscuous sex with multiple partners, for example, which they won't tell you anyway, even if you've known them for quite some time and you have a good therapeutic alliance. People don't like to talk about that, but they'll talk about not needing to sleep as much. Bipolar type 2 is a case where you have to have a history of at least one hypomanic episode and no history of having a manic episode, but you do need that history of a major depressive episode. It's a peculiar diagnosis and one that I have concerns about in that, did I miss a history of mania? Will they eventually become manic? I'm kind of careful there. In people with bipolar type 1, the ratio of major depressive episodes to manic episodes has been estimated as about 3 to 1. And the majority of their symptomatic time, as we went over earlier, is spent in the depressed phase. Now, it could be because the mania is so obvious that they're brought to treatment, and the depression may have flown under the radar and they may be slow to treatment. That's certainly a possibility. In patients with bipolar type 2, it's more controversial, this ratio of major depressive episodes to hypomanic episodes. One study suggested it was as high as 39 to 1, but not everyone agrees with this. There's also a caveat that we need to consider. DSM-4 and DSM-5 are different in terms of the mixed episode story. DSM-5 essentially eliminated the mixed episode as a possibility. The mixed episodes classically in DSM-4, for example, was simultaneous major depressive episode and mania for at least a week. That's kind of hard and very severe. So instead, DSM-5 allows a kinder, gentler way of describing this called the mixed feature specifier that we can use in either major depressive disorder or bipolar disorder. It's actually more user-friendly in terms of an outpatient practice where the mixed episode would be a very severe episode indeed. Now, clinically differentiating bipolar depression and MDD, we went over this already. Joe reviewed what he looks at as hints that we may be dealing with bipolarity. And so earlier age of onset certainly is a very helpful hint that we're dealing with something that's not plain vanilla MDD. More frequent history of a psychiatric disorder of a variety of kinds, so it's particularly bipolar disorder, would give us a clue that we're dealing with something like bipolarity. History of hypomania, of course, is going to be very distinctive. Atypical depressive features are more likely in bipolar disorder. And what do I mean by that? Well, sleeping more and eating more rather than sleeping less, or insomnia actually, and loss of appetite, which are more typical of major depressive disorder. Now, this difference in sleep, by the way, is very different from the manic experience of sleep. Manic people don't need to sleep. They have a lot of energy. However, major depressive disorder patients with sleep problems actually have a problem falling asleep, and they want to sleep and they're tired. And it's interesting, bipolar depression patients may actually be sleeping more, and you're wondering why. If there's episodic recurrence, that tells me I'm dealing with a episodic disorder. And bipolar disorder is your typical episodic disorder. MDD, not as much in many instances. Now, depressive symptoms are common, and they last a long time in many of our patients with bipolar disorder, and is the most common reason they come for care. I've never had a patient call me up in a manic state saying, I'd like to make an appointment to see you. I'm manic. It's never happened, not even once. However, happens all the time that when they're depressed. And because the symptoms of depression and bipolar disorder are very similar, if not identical, to MDD, we need to really look carefully at this past history. So there's some considerations for screening, and we do have a mood disorder questionnaire that can help us out a lot. And these are your typical questions that a savvy clinician will ask about a history of things that will make us think of mania. So these are right out of the DSM, essentially. Have you ever felt so good or so hyper, so irritable perhaps, more self-confident than usual, more talkative, etc., etc. These are things that depressed people ordinarily would not experience, even in their past, at least not to the same degree as someone with bipolar disorder. And if a patient actually endorses these symptoms or reports of symptoms, then that'll make you think of bipolarity. It's also a good idea at the same time to inquire about the degree of interference that these symptoms may have had on someone's level of functioning, but the level of insight into this may be quite variable. So we'll screen patients with depression for bipolar disorder. It's been estimated that about 1 out of 5 people being treated for so-called major depressive disorder with an SSRI or SNRI in a primary care practice actually have bipolar depression. So it's out there. The MDQ is a very helpful self-report instrument, and that will help us and also try to get a handle on functional impairment. Sensitivity is not so bad, and specificity is not so bad, but not perfect. So we'll still need to use our clinical skills and our clinical judgment. But we can use these tools. They are validated, they are quite helpful, and we'll supplement it with additional history that we gather not only from the patient, but from collateral sources. So we have to use our brains, our clinical judgment, and really think things through. And it helps us evaluate our case scenario. Sue. She's a 35-year-old woman and presenting with depression. She reports that she's sleeping a lot and has no energy. The sleeping a lot is a little unusual, but not out of the realm for someone with plain old major depressive disorder, but it perks up our interest here, especially since we find out she has a history of major depressive disorder since adolescence. Boy, she's been ill for a while, and she's had multiple episodes. Makes us think this is not your typical story. She's been previously treated with SSRI monotherapy based upon the MDD diagnosis, perfectly reasonable, but she didn't improve. And she has this history of hypomania. Her chart shows several hospitalizations for manic episodes on top of that while on the SSRI, and she doesn't remember the details. There's a history of potential substance use, such as alcohol and perhaps more. Through the family history, we find out that both her aunt and her grandmother had bipolar episodes. Now, when we look at all this information, Sue's presentation and history do not support MDD, actually. It supports bipolar disorder. The big giveaway is not only the hypomania, but hospitalizations for manic episodes while on an SSRI. That's a dead giveaway. DSM-5 now allows us to use that information as part of the diagnosis of bipolar disorder. Wasn't always the case, right, Joe? We used to only be able to say that it made us suspicious for bipolar disorder when we would see this, but now DSM-5 actually spells it out. If you have hypomania or mania on an SSRI that was induced, well, you have bipolar disorder.
Well, the nuance in DSM-5 harkens a little bit to DSM-3R in that it would say if an antidepressant is a catalyst in provoking an underlying vulnerability to bipolar disorder, this is where it gets a little tricky in clinical practice. In the laboratory world, withdraw the antidepressant, and if the symptoms of mania or hypomania persist at a syndromal level beyond the duration of the effect of the substance once it is gone, then you're allowed to call this a manic or a hypomanic episode. And the problem I have with that, and sort of have your research hat and your clinician hat, is who's going to sit there for 7 days and say, tell you what, we're just going to watch you and not intervene or do anything and just see if this all resolves with time. So on a practical level, it gets very difficult. And the concept being, if you take a medicine and you have some adverse effect, how do you know if it's an adverse effect or if it's an unmasking of something? If I give you an antihistamine and you get very drowsy, I don't say, well, you have narcolepsy, unless you're still drowsy a week later, I suppose, after the substance is gone. So here, as you mentioned, Les, is where we really got to sort of do our digging. This has happened more than once. Presumably, if you're in the hospital for 5 half-lives, what did you look like later? Sleep becomes a very important phenomenon to pay attention to in the hospital. First question on rounds in the morning, how did the patients sleep? They were up at the nursing station at 3 o'clock in the morning. Manics are sociable, they go up to people, right? So there's all these data points that I think we get when we assess someone with as complex a history as Sue. And it looks like we've got some charts we can read, maybe some family members to talk to, so that even though Sue does not remember the details, others might.
Yes, and I'm sure you do your digging, you'll find the answers that you need. Now, she's complicated with a substance use history, and that actually makes us think a bit more. Is she using substances because she's manic? Is she using substances because she's depressed? Or is she depressed or manic because of substances? And very often it becomes a circular argument. Bottom line is she has symptoms that we need to treat, and we need to effectively treat them. So, Joe, take us through treatments that are feasible today.
So back in the day when Les and I were in training, we didn't so much talk about bipolar depression as a thing because we didn't really have treatments that we thought were specific to bipolar depression. We talked about depression, and there really wasn't much concern or recognition about whether so-called traditional antidepressants were different in people with bipolar disorder than in unipolar disorder. It really wasn't until the late 70s and into the 1980s that studies began to emerge speculating a few things. One was, if people have bipolar disorder, is there a higher chance that an antidepressant could nudge them out of a down and into an up, sort of a phase advancing their illness, or increase the frequency of subsequent episodes down the road? And then came some studies saying, and if you do have bipolar disorder and you're depressed and you take an antidepressant, is it even going to work as well? And over the last 20 some odd years, we've learned a lot about how there are limitations of antidepressants, which prompted research in other kinds of psychotropic compounds to treat bipolar depression. So we'll talk more about antidepressants in a moment, but here we have at present the 4 FDA-approved treatments for acute bipolar depression: lurasidone, which is Latuda; quetiapine, that's Seroquel, either the immediate or the extended release formulation; the combination of olanzapine plus fluoxetine, OFC, with its proprietary name Symbyax; and lastly, most recently, is cariprazine or Vraylar, and other compounds that are of interest and in development. So to just briefly look at these, their indications all are to treat acute episodes of major depression in adults with bipolar I disorder. There are some nuances. Lurasidone has both monotherapy and adjunctive therapy data with lithium or with divalproex, so either alone or with a standard mood stabilizer. Quetiapine as a monotherapy and also has some maintenance data in bipolar disorder, which lurasidone at present does not. OFC, olanzapine fluoxetine, has data both in children, adolescents, as well as in adults, as does lurasidone. Those two are the only compounds that have an FDA indication for pediatric bipolar depression: olanzapine fluoxetine combination and lurasidone. And then again, most recently, cariprazine or Vraylar has its indication as a monotherapy, both for mania as well as for the depressed phase of bipolar I disorder. All of these compounds are indicated in bipolar I disorder. The data with quetiapine also includes some data with bipolar II patients. Now, lastly, on this slide, we can talk about mechanism of action. And as I like to say, we truly don't know what the mechanism of action is of these drugs. In fact, every psychotropic compound in the PDR lists the same mechanism of action, not well understood, not known. These are inferences from preclinical studies. So they're engaging for neuroscience-minded people to talk about, but they really do remain some subject of speculation. So let's speculate. So none of these are SSRIs. Lurasidone, apart from being an antipsychotic, that is binding at the D2 receptor, which we don't think has a whole lot to do, D2 antagonism with bipolar depression, does other things. It has an interesting binding affinity at the 5-HT7 receptor as an antagonist, as well as the 5-HT1A receptor as a partial agonist, both of which are subtypes of serotonin receptors that are thought to play an important role in mood. There are some monoaminergic antidepressants that are also 5-HT1A partial agonists and 5-HT7 antagonists. So we're curious and intrigued by that aspect of this molecule. Quetiapine has an active metabolite, norquetiapine, which has some binding affinity at the norepinephrine transporter. Is that pharmacodynamically influential in its antidepressant effect? Speculation. Also has binding at the 5-HT1A receptor and other serotonin receptors as well. Olanzapine fluoxetine combination. This is the one exception to the notion that monoaminergic antidepressants may be tricky business in bipolar depression, because fluoxetine is an SSRI, but when uniquely paired with olanzapine, you get synergy. That first was observed in unipolar depression studies of MDD patients not getting well enough with fluoxetine alone, for whom olanzapine was added on, and we saw about a 50% improvement in the earliest of those studies compared to patients who just stayed on fluoxetine alone, much lower degree of improvement. That then prompted studies in bipolar depression and some mechanistic preclinical data saying, you actually see more turnover in the prefrontal cortex of serotonin, norepinephrine, and dopamine with this unique combination. So there may be something about this unique combination that has a marked monoaminergic effect in the brain. And then cariprazine, Vraylar, is the only D2, D3 partial agonist of the three that exist that has both data, positive data, and an FDA indication in bipolar depression. The others either don't have data or don't have positive data. So it invites us to speculate about, is there something different about this agent as a partial agonist? Some people talk about that as kind of like a rheostat for dopamine. That is, in dopamine circuits that we think are down regulated, could a partial agonist bring up dopamine tone, say in the prefrontal cortex, and potentially downregulated in areas where it's too high. So cariprazine has the highest binding affinity at the D3 receptor. It's a receptor that's especially important in the reward pathway, motivation, drive, initiative, perhaps anhedonia, in addition to its effects on the 5-HT1A receptor. So again, the mechanisms are speculative, but they go beyond just dopamine. Now back to antidepressants. Guidelines recommend not using monotherapy. Inconsistent evidence across randomized trials may induce mania or hypomania, mixed states, rapid cycling. Some debate about whether they worsen bipolar depression and increase risk for suicidal behavior. There's some mixed data on that. I think, again, that the two main concerns are, could there be a potential worsening of mania symptoms? One thing we know from studies like the STEP-BD trial that our group was involved in some years ago is, if someone has bipolar syndromal depression with any concomitant mixed features, a la the DSM-5 specifier, antidepressants in that setting have a knack for inflaming the mania symptoms without suppressing the depression symptoms. So this makes it really important when you're sitting with a patient that you now know has bipolar disorder and they're depressed, to say, I understand you are very forlorn, sad, melancholic, suicidal, but I need to assure myself if there's anything on the opposite side. Do you talk fast? Do you have decreased need for sleep, as Les was saying, not just insomnia? Is there this sense of inner turmoil, psychomotor activation going on? Because in that setting in particular, antidepressants may clearly make things worse. There's some studies suggesting that. So the subtype of patient that may be even a candidate for an antidepressant in bipolar depression is a pretty small segment of patients. People with bipolar 1 disorder often will have some degree of mixed features. They may have a higher risk for switching into mania than bipolar 2 disorder patients, some research to suggest that. And then there's potential for increased cycling over time. But again, the biggest concern of all is there's never been a single positive study with any monoaminergic antidepressant. You're going to say, what about the OFC data? I'm going to say that is the one exception, and it's only O with F, not anything else with F. So does that mean we should do more studies? And there was an old study in the 1980s looking at lithium with fluoxetine. It didn't separate from placebo. So who is to say it is the one exception to the rule? How would you feel if you had this lethal illness and your doctor says, well, let's give you something that's never been shown to help your problem before? You know, you'd like to feel that there's a sense of confidence and an evidence base in what you're doing. And with these 4 FDA-approved treatments, it relegates monoaminergic antidepressants to, at best, an experimental category. And now Les is going to tell us about p-values and beyond.
So this brings us to figuring out which medicines are most helpful for your individual patient. And we want to reassure ourselves that these medicines work. We're all very happy to see p-values that, the p-value threshold is met, that there's separation of drug versus placebo at a threshold of 0.05, and that's supposed to impress us. However, it doesn't tell us anything about the usefulness of a medicine. It tells us if there's a statistically significant difference and the difference is probably real. That's about all it says. It doesn't tell us about the treatment effect size. So it tells us simply about how strong the likelihood that what we're seeing is probably the truth. The smaller the p-value, the more convinced we are that what we're dealing with is not just random, but it doesn't say anything about the size or the importance of the non-random effect. It's not the same as an effect size. So we can't use a p-value instead of an effect size to tell us about the importance of a study outcome. So when you see a result, p-value less than 0.05, another one less than 0.001, it doesn't mean that the one that's less than 0.001 is any more important or different than less than 0.05. It doesn't really answer that question. So let's take a look at what evidence-based medicine is all about. Evidence-based medicine is the incorporation of evidence, of course, together with your clinical judgment, together with your patient's values and preferences, all mixed together. It's a complex decision-making process that involves you and the patient in a very individual pursuit. What will work and what can cause a problem? And we're faced with an array of choices to make. And each of these choices have their different personalities. So each of those 4 medicines that Dr. Goldberg reviewed with you have their own personality when it comes to side effects, for example. We can quantify how important these effects are using number needed to treat and number needed to harm. How do we do that, you ask? Well, number needed to treat answers the question, how many patients would you need to treat with one intervention instead of the other before you would expect to encounter one additional positive outcome of interest, like one additional patient who's a responder or a remitter? And if we compare, let's say, a medicine versus placebo, we get an idea from the clinical trial how many patients needed to be randomized to that drug instead of placebo before expecting to encounter one additional responder. The smaller the NNT value, the more often we'll encounter success when using that intervention. Now, suppose all the drugs that you're considering have been compared against placebo. Well, then you have a common platform in which to indirectly compare agents with each other. They've all been compared with placebo. How well does each drug perform versus placebo in terms of number needed to treat for response or remission? And we also have its evil twin, number needed to harm, NNH. How many patients would you need to treat with the drug instead of placebo in a randomized clinical trial, for example, before expecting to encounter one additional patient who experienced weight gain of at least 7% from baseline, who experienced an adverse event of akathisia, who experienced an adverse event of somnolence? Again, the lower the number needed to harm value means the more frequently we'll encounter this issue in day-to-day practice. What we want to do is match up the patient that we have in our office with the medicine that we have on hand to consider. So this involves thinking about efficacy. Does the treatment reduce symptoms? Think about tolerability and safety. Does the treatment cause side effects that the patient cares about? And is the patient going to adhere or persist with the treatment? In order for a drug to work in the real world, or is the drug going to be effective, we need to consider efficacy, tolerability, and adherence. It comes in a package. So NNT and NNH is a form of looking at treatment effectiveness if we assume that the patient's going to buy into this decision and be adherent. An intervention should have a small NNT to show that the benefit is large, that is, encountered frequently, and a large NNH in value to demonstrate that the risk of harm is small or encountered infrequently. And we want to look at this over time. So what's a clinically relevant NNT? A small NNT is huge. It means for every 2 people who are given one treatment instead of the other, will encounter a difference. Well, that's very often in medicine that we don't have very many treatments that have an NNT of 2. I can think of, on one hand, the treatments we have in psychiatry that have such a large effect size. In essence, single-digit number needed to treat values versus placebo in a clinical trial are important enough for us to notice in day-to-day clinical practice as potentially efficacious and effective. So what's a single-digit NNT? Less than 10. So 9876543 and the lower, the better. Now, a large NNT of 100 or more means there's little difference in selecting one drug versus the other, or a drug versus placebo for that matter, because if it takes 100 patients to be treated with one versus the other before we encounter one additional patient with that outcome, well, that's a lot of patients. And we don't see 100 patients a day, or at least we should not. And so we won't notice this. Now, some NNTs may be clinically important, even if they are relatively large. For example, when the outcome is death. So how does that come up? Well, person with hypertension, they have low, mild hypertension, and the number needed to treat value to avoid a stroke, heart attack, or death over a 5-year period is in the hundreds. But you know what? I don't want to get a stroke or a heart attack or die early, so I'm going to take my antihypertensive, even though the NNT is like 100. Now, what if your blood pressure is really high? Well, then the number needed to treat actually to avoid heart attack, stroke, or death is like a 3 or 4 over a 5-year period. So you bet your bottom dollar that if you have truly severe hypertension, it's going to have a clinically, critically important effect. Mild to moderate, you can take your chances, but I wouldn't. Now, some NNTs may be clinically irrelevant. So let's say you have a number needed to harm of 5 for dry mouth, mild dry mouth. Will that change your opinion about the medicine if you were having to take it? Well, probably not, unless I'm a really sensitive kind of person when it comes to dry mouth. Now, what are the outcomes of interest in the clinical trials of bipolar depression? Well, they include response and remission in order to calculate number needed to treat, NNT. MADRS responders, Montgomery-Åsberg Depression Rating Scale responders, are defined by having at least a 50% reduction from baseline to endpoint on their total score. Now, if you go from a 30 to a 15, you're still depressed. So I'm not satisfied with just response. I want remission. Total score of less than or equal to 12 or 10, depending on which threshold you prefer. Frankly, if I was a patient, I'd prefer 8 or 6 if I could. But, let's be realistic. Look at averages and how these drugs perform in large groups, and 12 or 10 are a reasonable compromise in sort of to have a global assessment of remission. Number needed to harm? Well, I'm interested in weight gain of at least 7% from baseline. That would be a problem in a short study lasting 6 weeks. An adverse event of sedation or somnolence I'd be unhappy with if I had to function. An adverse event of akathisia I'd be unhappy and I'd be very uncomfortable. But it really could be any adverse event that would be of interest to the patient and the clinician. Let's take a look at MADRS responders first in NNT versus placebo in the clinical trials for bipolar depression. Well, they're all in this range here of, okay, bordering on 10 and below. They all work reasonably well. And we can take a look at the 95% confidence intervals. Those are the vertical lines straddling the number needed to treat estimate. And we find that they generally overlap. So for the most part, we would say these medicines work. Some may work a tad better than the other, but it's all pretty close in government work, so to speak. What about MADRS remitters? Same deal here. Well, we have on the border here 11. That's not so great, but it is close enough to 10, and the 95% confidence intervals do overlap, so I'm not terribly worried about it. If it has some tolerability advantages that make it a compelling choice, then yes, I might go for it. Lurasidone, quetiapine, and olanzapine fluoxetine combination are in the same, they're in a lower bracket. They still overlap, too close to tell. The other thing to keep in mind, though, is that the lower the threshold for remission, the harder it is to meet. And actually, that number needed to treat of 11 used a lower threshold. So it was a tougher bar to cross. But still, in the end, we'd say, hey, response remission, pretty much equivalent across the spectrum of the FDA-approved choices for bipolar depression. What about adverse events? Well, here is where drugs are different and they have different personalities. For the sake of ease of comparison, I created this heat map. Red means number needed to harm values less than 10 and relatively high risk for encountering that particular problem. Yellow is an intermediate risk for a number needed to harm between 10 and 19. Usually okay, you don't see it that often, but it can come up from time to time. Number needed to harm values of 20 or greater usually represents a lower risk, and I'm pretty confident it's not going to happen on my watch that day, but it could, I guess. But the reds will happen every day. So what are the reds? Olanzapine fluoxetine combination and weight gain, as you would surmise, have a number needed to harm value of 6 when comparing OFC with placebo, which means for every 6 people randomized to OFC versus placebo, you would encounter one additional patient who has gained at least 7% of their initial body weight. If you look at the number needed to treat for response or remission, it's about the same. So you can say you'll encounter weight gain just as often as you'll encounter response or remission. Not a good thing if that person is really concerned about weight gain and you're worried about it. Somnolence is the big Achilles heel for quetiapine. Works reasonably well, but the number needed to harm is 3. 3, for every 3 patients randomized to quetiapine versus placebo, you would expect to encounter 1 additional patient with a complaint of somnolence. And if this is persistent and impairs day-to-day functioning, it's a no-go. You'll actually encounter somnolence more often than response or remission just by looking at the absolute value of number needed to harm compared with the number needed to treat values for response or remission. All those other numbers represent yellows and greens. I'm not that terribly worried about them. Bottom line, it looks like lorazepam and cariprazine are well tolerated. And as such, more likely than not, patients are going to adhere to something that's well tolerated. And if it works for them in relieving their symptoms, then it's a winner for them. But this is complex and challenging. Joe, how challenging is this?
Well, gee, I'm looking at, it looks like it's easier being green than not. And I haven't yet treated 5,000 patients, I don't think, with bipolar disorder. So I'm comforted by some of these numbers. This is very useful information. But let's bring this into real world practice, because these are monotherapy studies in FDA registration trials with active comparators or placebo comparators. Very helpful building blocks for the average clinician in practice. But the average clinician in practice is often working with more than one medicine. So on the next slide, we can talk about one of the challenges in bipolar disorder and its complexity is medication burden itself. In an ideal world, wherever that is, one medicine should do everything. It should treat the heterogeneity of this illness, the highs, the lows, the comorbid anxiety, the comorbid substance use. It should normalize your sleep-wake cycle. It should help your cognitive symptoms. It should have no side effects. It should help with your medical comorbidities. It should grow hair. It should do everything we'd want it to do. And we don't have that yet. So combination therapy or polypharmacy is increasing over the years. It's about 1 in 3 bipolar patients nowadays takes 3 or more psychotropic drugs. About 20% takes 4 or more psychotropic drugs, and there's a standard deviation to that. Sometimes combination therapies are very artfully put together. You can capitalize on the pharmacodynamic effects of one drug and hope for some synergy with another, or try to target a comorbidity with this drug augmentation to that drug. But sometimes, for reasons that are not always obvious, medicines may stay in a regimen that don't necessarily belong there. It may be an obsolete drug. We've all seen patients who come in and they're very depressed and they're on a certain medicine, and you wonder, why are they on this drug? And they say, well, because they're depressed. And you wonder, well, I know, I see you're depressed, but this is proof the medicine you're on either isn't working, or you would be so much worse off without this medicine than with it. So I always like to ask patients, if you're on something and you're still very symptomatic, do you have a recollection of whether it's had any value and lost it, or it was just sort of tried and just kind of left there? Because combinations can make sense, but we also want to deprescribe drugs that don't make sense. We just get additive side effects, and then that interferes with adherence. So combination therapy is a tricky proposition. This is a next slide from the STEP-BD study, where we actually found most patients were on adjunctive therapy. Monotherapy mood stabilizers was only about 1 in 5 patients. And one thing I like to point out from this study, which I did, was that one of the biggest predictors of the number of medicines you got prescribed, this is walking in the front door, coming into the STEP-BD. So before we got our hands on the patient, just coming in, one of the biggest predictors of the number of medicines you got was how many depressive episodes you'd had, which was a sobering observation when we found that, because it seemed to suggest that depression is really this hard to treat thing, and practitioners will throw everything in the kitchen sink at it. I remember going through the data in this study. I remember a patient on 22 psychotropic drugs, still very depressed, and they were reluctant to stop any of them because they were afraid they'd get worse. And we did the STEP-BD trial. So depression is really burdensome, and patients cling to lots of medicines, even if they're not necessarily working. It is so important to know these points that you're making about low NNTs. Why walk around on 22 medicines with high NNTs for naught? It's just, it defies logic, other than speaks to the fear of just how awful this illness can be. Patients are putting up with so much. We said a little at the beginning about the medical comorbidities, and I just want to emphasize here, people with bipolar disorder are at higher risk for metabolic dysregulation. Over half will have metabolic syndrome, which puts them at an increased risk for a myocardial infarction or cerebrovascular disease. I mentioned many of them spoke. Obesity is prevalent. We can think about things like sleep apnea being present, sedentary lifestyle. There's so many factors that go into the excess cardiovascular and cerebrovascular morbidity and mortality of our patients. We'd be remiss to not be paying attention to this when patients present to us with hypertension, with opportunities for making decisions about first doing no harm. That means drugs that are fairly neutral when it comes to the risk for dyslipidemias and glycemic dysregulation or weight gain. It's not just that the patient is going to say, well, I don't want to risk gaining weight. Give me the drug with the highest NNH for weight gain. It's more than that. We're really trying to improve their quality of life, not just by virtue of their psychiatric status, but a whole sense of vitality and medical health hand in hand with psychiatric well-being. So we may be the only healthcare professionals that have that dual awareness of these factors, and these are patients that really come to the forefront with those dual factors. So collaborative management with primary care physicians, internal medicine doctors, like to be sure we know who is weighing the patient, checking lipids, checking glycemics, for that matter, checking thyroid hormone, and organ monitoring. More and more psychiatrists and other healthcare professionals in mental health are becoming involved, either directly or indirectly, in a collaborative way about assuring that our treatments are safe as well as effective. So these are all important points we want to be mindful of, make the patient aware of them, recognize the family is aware of this, so that if somebody walks in on 22 medicines, we'd like to be very thoughtful. I will tell patients, think of medicines like employees on a payroll roster, and every employee needs to earn their position in the team or on the payroll. And if we can't justify why medicine is there, and it becomes a liability, that's no good for anybody. So common psychiatric comorbidities, you touched on these a bit earlier. Half of people with bipolar disorder will have a second psychiatric diagnosis, or a third diagnosis, or a fourth diagnosis. A quarter will have as many as 4 psychiatric diagnoses. And here are the most common ones that we'll see: anxiety disorders and or symptoms, behavioral disorders, substance use disorders, eating disorders, binge eating disorder. ADHD can occur in STEP. We found 10% of adult bipolar patients with ADHD. So this adds to some of the confusion potentially about accurate diagnosis versus comorbidities. It means taking a very careful history, because the symptoms that we see can't be better accounted for by something else. People that are manic and distractible and say, I think I have ADD, let's treat your mania. People that are depressed and have poor concentration and think, I have ADD, let's treat your depression. People that are psychomotorically activated and think they have ADHD, let's treat your agitation. And then we can look more carefully at some of these comorbidities, because if they're truly there, they do need their own treatments, and they can be harder to treat. So we have to assess comprehensively, and don't necessarily assume that if you treat one diagnosis, all the others are going to wipe off the map. So the patient with an active substance use disorder might be using substances the same as they may be spending a lot of money or doing impulsive, reckless things, where you hope that if I can syndromally treat a mania or a mixed features presentation, some of the other associated features may get better. But don't necessarily assume that to be the case. You may want to have a hierarchical approach. Let's put out the flames of a mania or a syndromal depressed phase, and then we can look more carefully at residual symptoms, subsyndromal symptoms, their interface with other diagnoses, and then hierarchically treat them, not just pharmacologically, but oftentimes with psychosocial treatments as well. So here's a case. Mike, 57-year-old man, presents with depression, history of bipolar disorder, initially was identified as having major depressive disorder, cardiovascular disease and diabetes, so 2 risk factors for MI. Family history may not be evident. It isn't always evident. And one of his concerns is we want to have weight gain. One of our concerns is we want to first do no harm. But we also don't want Mike to wind up on 22 medicines that have no value or bearing. So we want to be thinking of what's going to be efficacious. That means it's going to work. And effective. It means he's going to stay with it. He's going to be engaged and involved. He's not going to say, I'm gone after just 2 or 3 weeks. We really are trying to engage Mike in treatment, and recognizing his concerns really speaks to shared decision making. That means sitting down with Mike and talking about a mutual awareness of what he wants to see accomplished, what the reasonable options are. If Mike says, well, would such and such medicine work? And there's no evidence for such and such medicine. We may know this is a drug with a very high NNT, or this is a drug that's never been studied for bipolar depression. We bring to bear knowledge and expertise there. Otherwise, we could have the most efficacious treatment anywhere, but we won't have the buy-in, we'll lose effectiveness, and then we worry about non-adherence. So many things will go into non-adherence. Certainly, if the drug's not working, we would expect that's going to make it harder to have someone stay on a medicine if it's ineffective. They may not recognize the need for it. Probably had patients who the second they're better say, well, can I stop the treatment right now? No orthopedist, I guess, puts a cast on someone and then 5 minutes later, can we take the cast off? So we have to educate about the illness. Historical non-adherence becomes of concern, supports family attitudes about medicines. Are they helpful, or are you still taking that medicine? We want to get a comprehensive sense. Try to simplify a regimen as best as possible. So extensive polypharmacy tends to drive non-adherence, having a strong therapeutic alliance, and motivational interviewing. That means helping the patient recognize what their own goals are. So how do we achieve best practices in patient education? Les is going to tell us how to do that.
Well, it's essentially what we've been talking about, engaging the patient in the treatment choices being offered and making sure that their adherence to the best they can. We can only do that with a collaborative attitude and forging an alliance. We have to address any misconceptions they may have about treatment. We have to align with their goals, really what they want. We want to restore function for function that's been lost. We want to control symptoms, of course. And bottom line, we want to prevent relapse. So it's one thing to treat acutely. Hopefully we'll spend very little time in the acute phase of the illness and most of our time keeping patients well. The chronic disease management model is very helpful in this regard. It acknowledges that some disorders are lifelong. Bipolar disorder is lifelong, and the treatments that we have will stabilize someone, but also help them along in the long term. They'll need some help with self-management tools, decision support, community supports. We need to align our delivery systems to make it easy for them to do this. And we need to share information in an effective way amongst the different providers. Our health system has to cooperate because it's not just, of course, the mood problem, it's also all the comorbidities. So to summarize, we went over a lot of material. Joe, take us home.
So accurate diagnosis is critical to optimizing outcomes, preventing the use of inappropriate medicines, as well as ineffective or non-efficacious medicines may increase the risk of adverse outcomes. I'll add to this, accurate diagnoses, since most patients with bipolar disorder have more than one ailment. Screens are important. They're a good entry point, a good starting point. You want to capture all the cases. You're looking for cases, and then you can winnow that down. You don't want to miss people when you screen it. So it's a good entry point for doing a thorough diagnostic evaluation. When someone presents with major depression and a history of a mania or a hypomania, and we identify them as having bipolar 1 or bipolar 2 disorder, we now have an evidence base for treatments. For bipolar 1 disorder, we have 4 FDA-approved treatments. We've talked about them: lurasidone, cariprazine, olanzapine, fluoxetine combination, and quetiapine. And we can tailor our treatments based on the patient's profiles and their individual needs. As Les mentioned, this is a lifelong condition, but it's an optimistic condition if we can effectively and successfully treat it and tell patients, let's get you into remission and keep you there. And if we're doing a good job, you won't see me very often. And if things are not going as well, we want to be sure we're catching things and getting on top of things and addressing non-adherence and addressing comorbidities to try to maximize optimal outcomes. We want to be mindful of cardiovascular and metabolic comorbidities that are common, both for the patient's sake, for our collaborative efforts with other healthcare providers, and in choosing safe as well as effective treatments. Since collaboration is key, it takes a village, it takes a team. It's part of what makes this illness challenging and often very gratifying to treat. And with that, I believe we are done with our formal presentation, and we will be turning now to questions from you.
Thanks so much, and let's start with the questions.
And I see 3 questions here in the question area on our screens. Do you ever use antidepressant therapy when treating patients with bipolar disorder? Dr. Goldberg.
Oh, I would love
ever
to
do this.
Ever. Well, the giveaway question here is the word ever. So let me quote, if I may, from the International Society for Bipolar Disorders Task Force on Antidepressant Use in Bipolar Disorders that was published in the American Journal in 2013. This was 66 experts convened to answer questions very much such as this. if I can quote, the task force could not make broad statements endorsing antidepressant use, but acknowledged individual bipolar patients may benefit from antidepressants. And of the 12 items that we tried to get consensus on, which was not easy to do, the one most important point of consensus was that there is no general rule. You can't make a general rule. You have to talk about patient-specific characteristics. So here's where it gets a bit complicated. Most bipolar depressed patients are not excellent candidates for antidepressants, mainly because they haven't been shown to work in the small number of randomized trials that have been done with a small number of antidepressants. None of the antidepressants developed after 1999 has ever been studied for bipolar depression, so class effects are a little tricky to make. But to the best of the literature, the biggest risk with antidepressants is the ones that have been looked at, namely paroxetine, bupropion, fluoxetine plus lithium, venlafaxine, have not shown a robust effect in bipolar 1 disorder. By contrast, there are some small proof of concept randomized trials in bipolar 2 that show excellent safety and efficacy in small randomized trials with fluoxetine, even as monotherapy in bipolar 2 patients, and sertraline in bipolar 2 patients. Those SSRIs have even beaten lithium for acute bipolar depression and relapse prevention. But here's the trick. It's a very select sample. We're talking about using antidepressants, perhaps in bipolar 2, not bipolar 1 patients, without mixed features, no mixed features. Les was describing this broadened DSM definition. So any mania symptoms with depression bodes poorly for antidepressants. History of rapid cycling bodes poorly for antidepressants. History of recent mania bodes poorly for antidepressants. History of a poor response bodes poorly. So you cone it down to about 10% of bipolar patients that are good candidates, which is to say the vast majority are not great candidates. But I think you have to go through the exercise, as with any drug, of deciding if someone's a good candidate for it.
Yeah, so never say never, but it is not the normal course of events. And it's something I try to avoid personally. I don't like the potential of someone becoming manic. When someone becomes manic, they are at risk for doing stuff that really has very severe consequences to their marriage, their employment, their life. So something you want to avoid, even though it doesn't happen all the time. You know, people don't get antidepressant-induced mania every time they're on an antidepressant. But all that has to happen is once in your clinical experience, and then you're going to really be very gun-shy about it.
And this was a key point from the ISBD panel, was that bipolar 1 probably is very different from bipolar 2.
Yes.
Or from bipolar unspecified, or patients who are in the soft spectrum. We don't know much about how they do with antidepressants.
Yeah. That being said, there are patients who do benefit from being on an antidepressant. When they're removed from it, they are worse. When they get it back on board, they're better. And so that's the N of 1 trial that really spells it out for them. So what factors influence your choice of an approved treatment for bipolar depression? Well, that's an easy one. Let me take the easy one, Joe. So there are 4 approved treatments, at least FDA-approved treatments, and they're all different. And what I try to do is match up the patient and what they would like in a medicine with what's available. So olanzapine fluoxetine combination is not out of the question. Quetiapine is not out of the question, even though they come with baggage. And certainly lurasidone and cariprazine are, they are frankly better tolerated when you compare groups of people, but they're not for everyone. So I'm really glad to have 4 choices that are different. It's certainly better than having one choice or no choice. And hopefully we'll have more choices in the future. So what I look for is their past history of what they've been on and what has worked. And if they haven't been on anything, what are they wanting to avoid in terms of side effects? And this differs a lot from person to person. Some may be fearful about being slowed down or sedated, others being restless, and others worried about weight gain. And it's never the same reasons. And what's important to one person may not be important to the next. So that's why I like choices. Do you do anything differently, Joe?
No, I would only add to that, be careful about, we're in a CME program, so I'm going to say be flexible when you talk about approved treatments. We are talking on label about FDA approved treatments, but that's not necessarily synonymous with all of the evidence-based treatments. There are evidence-based off-label treatments for bipolar depression with meaningful effect sizes. For example, Divalproex is off-label for bipolar depression, but actually has a large effect size in a recent meta-analysis. Lithium plus lamotrigine is superior to lithium alone for acute bipolar depression. Intravenous ketamine, off-label for bipolar depression, has a large effect size and apparent safety data. So I always encourage colleagues to be mindful of the distinction between FDA approval and evidence base.
Yes.
Sometimes converge, but not always.
Yeah. So let's take lamotrigine monotherapy, for example. For bipolar depression, the number needed to treat is 12.
Yep.
Not really all that great, but then again, it is very well tolerated. So if you don't have many other choices, it's very low risk as long as you titrate it slowly.
That and also it's a pet example of mine. I think you and I are even going to do a symposium on this next week, Dr. Citrome, at the ASCP meeting on Friday, where we talk about failed trials. And the lamotrigine trials have a high-ish NNT, mainly because placebo worked really well in those studies. And in fact, our field is littered with studies of an agent not besting a placebo because the placebo worked too well. N-acetylcysteine, for example, has some nice data from our colleagues in Australia, but a very recent study had a huge placebo response rate that failed to show an advantage of the drug. So one has to read the literature and be very ferreting out of the drug versus placebo difference. And that's where something like the NNT that you talk so nicely about and importantly about means you're comparing to placebo, but placebo is not no treatment.
Right.
And if a drug trial has a placebo response rate greater than 40%, as occurred in the lamotrigine trials, it's hard to interpret.
Yep. And you and I, we were both pretty involved with Divalproex in its day. We're very enthusiastic about it, and we have to keep on top of the literature too, because since then we've now discovered, oh my God, what about the risk to women of childbearing age? And so that has turned Divalproex upside down in terms of how we place it in our list of choices to offer.
Sure,
So,
of course.
Yeah. So we have choices, we have data, and we need to keep on top of that data because it can change too. That was one example where, boy, did that ever change. So we hardly ever consider Divalproex to a woman who is pregnant, wants to become pregnant, or frankly, of childbearing age. Yeah. Anyway, that's another story for another time. There's a third or last question here that I see on the screen. In addition to the MDQ, are there any other screening tools or tactics that you use to determine if a patient has bipolar depression? So let me take that one quickly because we're running short of time. And that, yes, the MDQ is useful to look at hints of bipolarity, but we still have to get a good assessment of the severity of the depression. And what better tool is there than the PHQ-9 in terms of ease of use? People can fill it out. Doesn't take any extra time. You don't have to do a structured interview to get that information. And I'm often amazed on how patients perceive themselves and how I would have assessed how severe their illness is. I've seen on many occasions people who don't look that depressed. Hey, you don't look so bad, you're functioning well, whatever. And they felt at PHQ-9 and they scored 27. Now, how did that happen? Well, they perceive themselves as quite depressed, and that's what's driving everything about seeking treatment and wanting relief. So use a rating scale to assess depressive symptomatology when you treat depression. I don't care what kind of depression.
Yeah, and the MDQ doesn't assess current symptoms.
No.
It asks about a lifetime history of a mania. Actually asks about a lifetime history of a mania. It's really not that reliable for predicting bipolar 2 or bipolar NOS or cyclothymia. So the MDQ, as well as other measures, the questionnaire asked about other screens. There's something called the rapid mood screen, which our friend Roger McIntyre and others recently published. It's a 6-item self-report screen with high sensitivity and specificity. But an important point is that screens are screens. They're meant to widely capture all possible cases and not miss anybody. They're not there to winnow out the false positives as much, which is what you want from a screen. If you're doing a pap smear, you don't want to miss anybody. So you have to be careful about false positives. I've seen patients in consultation, as Les points out, you've got to really do an interview. And I've said, the patient doesn't really meet the DSM criteria for bipolar disorder. And the colleague will say, but their MDQ was over 7. So the screen can be positive. It doesn't automatically rule in caseness. If the screen is negative, it's got a pretty good negative predictive value. So in a busy clinical setting, if a patient fills out the MDQ in the waiting room and their score is comfortably below 7, you could probably move on comfortably to other kinds of questions besides just bipolar disorder.
Excellent points. Well, unfortunately, that's all the time we have for tonight. To our audience, thank you very much for joining us this evening. And for those of you viewing on Hybrid Live, you'll be redirected to the evaluation form. And to anyone viewing from another platform, you can claim your CME credits at integrityce.com/BP1 post-test. That's integrityce.com/BP bipolar 1 post-test. This link can also be found in the video description. Thank you, Joe, and good night, everybody.
Thank you, Les. Not all.